Hello, and welcome to our brief webinar on Section C of the MDS. We'll be discussing the primary cognitive test for this section, the BIMS, or the brief interview for mental status, as well as the staff assessment for cognition. MDS experts indicate that the BIMS is often inaccurately provided, resulting in cognitive issues being missed. Frequently, too many cues are given, so residents may appear more intact than they really are. So we want to spend a few minutes today, about 15 to 20 minutes, reviewing the BIMS and some of the scoring for Section C. Section C is important at this point in time because if no data is collected for Section C in the initial assessment, cognition cannot be factored into the speech component for payment categorization, nor is it captured for nursing case mix groups for behavioral or cognitive symptoms. Since so much is riding on cognitive information, it's recommended to gather this information as soon as possible in the SNF stay. However, we do understand that some providers may choose to complete Section C data a few days into the resident's stay to give them a few days to adjust. So Section C, as we know, is about cognition in the MDS, and the brief interview for mental status, or the BIMS, is the preferred assessment according to CMS. If the resident is unable or unwilling to participate in the BIMS, the staff assessment may be completed, and we'll talk more about that in a little bit. Cognitive assessment is going to be critical for optimal case mix scoring under the new PDPM system. The RAI manual that was released, the draft of it that was released on May 20th of 2019, indicates the following information. Because a PDPM cognitive level is utilized in the speech payment component of PDPM, assessment of a resident's cognition with the BIMS or the staff assessment is a requirement for all PPS assessments. And they go on to say that if a person leaves unexpectedly before the BIMS or staff assessment can be completed, the staff assessment can be used to gather data as available to complete this section of the MDS and support the speech payment component. So the BIMS is an objective standardized screening tool. The interview can be conducted if the person is at least sometimes understood verbally or understood in writing or through another method. It's recommended that the BIMS be provided in a quiet environment. The resident should have their hearing aids in place, and the interviewer should sit so that the resident can see your face with glare being minimized. And you need to use their preferred language and communication system. So be aware that might mean you need to use an interpreter. There might need to be somebody who can use sign language with this individual. They might be able to use their communication board. All of these devices are to be used so that we can get accurate cognitive scoring for that individual. The test should be provided by an interviewer who can pronounce all items clearly. And you need to say something to the person like, I'd like to ask you some questions. We ask everyone these same questions, and it will help us to provide you with some better recommendations. Some of the questions might seem easy, while others might be more difficult. And if the resident is concerned, reassure them with, we ask everyone these same questions so we can make sure to meet your needs. For the administration, because this is a standardized test, it's essential to only provide the cues per the instructions. It's real easy to accidentally say more than we should be saying to that person. So if they ask something like, is this the day the beauty shop is open, when you're looking at what day of the week it is, you need to reply with, I'd like you to answer the question without any help from me. So looking briefly at section C200 through C500, the BIMS starts with looking at a repetition of 3 words. And the interviewer says, I'm going to say 3 words for you to remember. Please repeat the words after I have said all 3. The words are sock, blue, and bed. Now tell me these 3 words. And if the person correctly recalls all 3 words immediately, tell them they are correct and still repeat those words. The order they repeat the words in doesn't matter. If the person recalls 2 or less words, repeat the words and categories again. And if they still cannot recall all 3 words correctly, you may repeat the words and category one last time. After 3 failed attempts, you want to make sure the person can hear you, and then you move on to the next question. Again, even if they correctly recall all 3 words, it's important to give that reminder to the individual, that repetition, so that they have a chance to learn the correct responses and encode that information. With temporal orientation, it's going to look at year, month, and day, and it starts by asking what year it is now. You want to give the person about 30 seconds to respond, And don't give them any cues, even if they look for validation, such as, isn't it 1988? Let them know you want to know what they know without your help. And if the person responds with just the last 2 digits of the year, like they say, oh, it's 19, ask them to give you the full year, such as, can you tell me the full year, as like you would say 2005? See what they come up with. When you're looking at what month it is, you need to count the current date as day 1 to determine the accuracy of the response. You might need to jot down the response and count up the days later to make sure that you're scoring this accurately. It can be a little bit tricky sometimes. And be aware that a score of 1 or 3 can be earned with a response for days in the future or in the past. So be aware when scoring the response to what month it is, the individual needs to be accurate within 5 days. If the date is June 29th and they say it's July, then they're scored as a 2 because they are accurate within 5 days. If the date is June 2nd and they say it's May, this would also be scored a 2 because it's also accurate within 5 days. However, if the date is June 25th and they say it's July, the score would be a 1. They missed the date by 6 days. And that would then relate to them being inaccurate for 6 days to 1 month. So again, June 25th is day 1. The current date counts as day 1. And that can be a tricky thing where I think some of those scoring inaccuracies might creep in if we're in a hurry and we don't quite think about the days that we're counting. When we ask the individual what day of the week it is today, again, they need to tell you a day of a week, not a number. So it's not the 29th, it's a Tuesday for them to say the correct answer. We're going to go back and look at the recall, and we're going to go back to an earlier question, is what we would say to the resident. What were the 3 words I asked you to repeat? Again, allow them up to 5 seconds for spontaneous recall of each word. For any word not correctly recalled, give the person the designated category clue, like a color, a piece of furniture, and allow another 5 seconds per word for recall after the clue to determine whether or not they are accurate or not. So scoring recall, if the person recalled several items in a category, for example, you ask them to recall the words and they start saying red, green, blue, yellow, that would actually be coded as correct because they did include the correct response in that list. However, if they received a cue and you said, well, it's a color or it's a piece of furniture, and they start naming off several items in that category, such as chair, table, bed, couch, that would not be coded as correct because they received a cue. They need to be much more precise and specific with their answer. So again, if you give them a cue, they need to be more precise. A listing in that category would not be correct. Some additional tips: if the person does not or chooses not to recall to answer an item, that would be coded as a 0, that they could not recall. If they're cued and they combine answers, they may be coded as correct. So for example, if they say the shoes were blue, you would code 2 for the items that they spontaneously recalled, 1 for the items that they needed cues for. So if they need the cue color and they say the shoes are blue, they're scored a 2 and a 1 respectively. 2 because they spontaneously recalled shoes, 1 because they received a cue for the color. This is again where it can get tricky sometimes, and I think this is where we sometimes get some inaccurate scoring. But when we look for the summary, we're going to add the scores for C200 through C400 and fill in the total from 0 to 15. If they're unable to complete the interview, they're scored as a 99. CMS wants to be sure that we understand the BIMS score does not determine a diagnosis of dementia. The BIMS, however, has been highly correlated with the mini mental status exam, and you can see the results of their BIMS score as to their cognitive status of being intact, moderately, or severely impaired. Some other scoring guidelines: nonsense responses are coded as a 0. If the resident states a year, even if it's the incorrect year, it is not a nonsense response. If they deflect responding, they make a joke, they're being sarcastic, they say it's a stupid question, everybody should know this, it's incorrect, but it's not nonsense. And if the person responds with an unrelated statement, it is incorrect and it is nonsense. Okay, so again, inaccuracies are not the same as nonsense. For a complete BIMS to have been done, the person has to attempt to provide a relevant, even if incorrect, answer to at least 4 questions. If a person chooses not to answer a specific question, that question is scored as incorrect. 4 or more refused answers result in an incomplete BIMS and a staff assessment is indicated. And even if you suspect that they know the answers but choose not to respond, score for the responses given. So they earn a 0 if they say it's a stupid question. Again, we know that sometimes deflecting a response can be their attempt to cover up some confusion or some cognitive decline. So we don't want to score for what we think they know. We need to score for what they exhibit. We need to stop the BIMS after asking the day of the week question, if the person has provided all nonsense answers to the previous 4 questions, or if there's been no attempt to respond to the questions, or if there have been either no responses or nonsense responses to all the questions up to this point. Then we need to stop the BIMS and move on to the staff assessment of mental status. And again, remember, a score of 0 on response does not indicate an incomplete BIMS, only indicates that there may be some cognitive impairment going on. So what to do if they can't or they won't do the BIMS, if they won't participate or they can't? We do the staff assessment. And that is actually an informal tool, but it is a bit regulated through CMS. It's going to gather information about observed recall after 5 minutes, long-term recall, orientation, and some general decision-making abilities. It's going to be way less objective and less reproducible than the BIMS. So again, the BIMS is the preferred test, but the staff assessment is the fallback test. So here's a brief screenshot of C700 through C1000, looking at short-term memory, long-term memory, recall, and you can see that these are really broad brushstroke generalized questions. So when we're looking at short-term memory, we might ask the person about an event that you know they participated in 5 minutes ago. If they just had a meal, if they just participated in a music program or bingo, do they recall that about 5 minutes after it's ended? You can ask long-term questions such as where they were married, do they have children, when is their own birthday. Orientation information from C900 is looking at things like the season, where is their room, do they know staff names, do they recognize staff faces, do they know they're in a nursing facility. Those are general orientation questions. And it's helpful to gather data from the staff of all shifts or from family members so that we can incorporate their observations about orientation and recall as well. If the person is non-responsive or completely uncooperative, and the staff is unable to observe for cognitive functioning, then the standard no information code and a dash should be used. Staff assessment of mental status, looking on a little bit more with decision making. Again, we're going to look at if they're independent, modified independence where they have difficulty in new situations only, do they need cues which would indicate moderate impairment, or if they rarely make decisions, it may be severely impaired. You want to note the resident's ability to choose clothing, when to go to meals, are they using environmental cues such as clocks or meal carts, do they ask appropriate questions about upcoming events, notice if they have insights about their own limitations or if they use assistive devices effectively, accurately, safely. And again, you want to note their actual ability or their demonstrated ability in these areas for making decisions, not what you think they're capable of doing, but what it is they're actually demonstrating the ability to do. So we need to stay out of our own inferences. With scoring, the cognitive performance scale is used to score the resident based on responses to the staff assessment of mental status. Previously, as in our current MDS version, the BIMS and the CPS produce separate scores, but PDPM, when it hits, has aligned those two scores. So we look at this screen, and this is from the CMS fact sheet. And when you go on the CMS website, they have a fact sheet that's titled PDPM, Functional and Cognitive Scoring. And the new PDPM cognitive score is based on the cognitive function scale, which combines scores from the BIMS and the CPS into one scale that can be used to compare cognitive function across all patients. And you can see the correlation chart here. Therapy input on observations related to the staff assessment can really help the MDS nurse in determining the cognitive status of those who are unable to complete the BIMS. Speech therapists often gather this data during a screening even. So communication between whoever is doing the BIMS interview and the MDS nurse is going to be essential for the most accurate assessment of a person's cognitive status. The BIMS or staff assessment of mental status can occur with or without the therapy input. We don't want to give the impression that therapy has to be involved in the cognitive assessment, but they can be a helpful team player. When appropriate, the therapy test results or observations can support better MDS accuracy and therefore improve PDPM case mix index when necessary. Again, careful BIMS assessment can justify therapy's course of treatment and the intensity of that treatment when cognitive issues are found to be a part of the clinical picture. So what if? We know the what ifs happen, and if the interviewer and the MDS nurse don't have the same findings related to cognition, the interviewer wants to give the MDS nurse what they know and allow the MDS nurse to complete that MDS part of the section C, incorporating their observations and the information they've gathered. Accurate scoring of section C is also going to support appropriate interventions from the entire interdisciplinary team. So again, accuracy is going to be essential. The interviewer for the staff assessment or the BIMS would want to be sensitive to the differences between delirium and dementia, depression, because those need to be properly addressed if there's indicators for that. The acute changes in mentation can also be a result of delirium, which is found in coding section 1310, and obviously additional medical workup could be indicated if there are delirium triggers. Some important details, and I'm reiterating this again, in order to receive a PDPM classification, all required items must be completed. Either a BIMS score or a cognitive performance scale score is necessary to classify the patient under the speech component. If neither the BIMS nor the staff assessment is completed, then the patient will not be classified under PDPM, and a PDPM HIPS code will not be produced for this assessment. So again, cognitive scoring is even more important than ever under the PDPM system. Some final thoughts. Validate cognitive status with objective information such as the BIMS or the staff assessment. Your speech therapist may also be providing additional tests as indicated to validate their cognitive status. Remember that section C needs to be completed by the 5-day ARD to impact PDPM case mix scoring. And again, very important when we're providing the BIMS, providing the staff assessment, only provide the designated cues. So at this point, I want to thank you for your attention to this webinar. Thank you for your scoring accuracy and taking such good care of your residents. Have a great day.